Hi, everyone. Thank you so much for joining us today for the webinar IVF Process and Technology. My name is Anastasia Timon. I'm a CEO and founder of Blumeneve. Blumeneve is a fertility platform that helps patients to get care not depending on where they are and improve an access to fertility care by allowing OBGYNs to do part of the fertility treatments monitoring. As you know, patients do not always live close to the fertility center or affordable fertility center or good fertility center. They also may have to travel for other indications and other reasons, such as they need to do the surrogacy or they have no coverage, or there is some unfavorable legislation like in Alabama recently. And that is exactly for that reason with Blumeneve platform, these patients can be treated and get a fertility treatment with their OBGYNs doing blood work and ultrasound throughout the cycle. Let me introduce you to our amazing speaker and the guest, Sunny June. Welcome, Sunny. Sunny is a board-certified reproductive endocrinologist. She is also our medical advisor and medical director and co-founder of CCRM San Francisco. CCRM is one of the most established fertility networks, I should say, in the whole of the US. Sunny also got a lot of the awards and honors throughout her training and career, so we are very honored to have her today. So yeah, and after that, I will just hand it over to Sunny, and we can start from there. Thank you so much.
The potential causes of infertility, of course, there's male factor, female factor. The female factor can be further categorized into ovarian issues or uterine issues or tubal issues. But then there's also another category called unexplained. And these are couples where they undergo testing and all the tests come back normal. That can cause some frustration in these couples. If you go back to the previous slide, Anastasia. So there are different types of fertility treatments, as you know, but IVF has become much more prominent over the years. And even a few years back, we were doing, let's say, around 200 to 250 cycles, and now over 400,000 cycles, 200 to 250,000 cycles, and now over 400,000 cycles are being performed in US alone annually. And about a third of those are due to fertility preservation, like egg freezing and embryo freezing, because more women are being more proactive and their awareness has increased. And IVF accounts for 2% of all live births in the US annually. Next slide. Next slide. As we all know, the trends in fertility, unfortunately, it declines with age, and the peak fertility ranges from the mid-20s to early 30s. And then after the age of 35, 36, there is that sharp decline. And then past the ages of 45, the rate of pregnancy is significantly low. Next slide. And that's due to the decrease in both egg quality and egg quantity. As we all know, women are born with a limited number of eggs, and by the time they're menopausal, we're only left with several hundred eggs. And that when we talk about egg quality, we're talking about chromosomal makeup of the eggs, and that significantly decreases in, or actually increases in the chromosomal abnormality rate with age. Next slide. How do we test or how do we assess ovarian reserve? As we all know, as OBGYNs, the standard cycle day 2-3 labs are done, and that includes FSH or follicle stimulating hormone, estradiol, and also LH levels. And these hormones are, especially the FSH and LH levels, are pituitary hormones that signal egg development. For FSH, we consider less than 10 to be considered within normal limits. If the estrogen level is less than 50 to 60, that's also considered within normal limits. However, sometimes the estradiol levels can be higher in the early follicular phase, and that could be due to one of the reasons, such as ovarian cysts, and that would then have a negative feedback and cause a suppression of these FSH levels and have a false result. And therefore, it is important to check both FSH and the estradiol. And if the estradiol is higher, then those tests need to be repeated. And cycle day 1 is considered the first day of full flow, not spotting or light bleeding, but first day of full flow. So that's important to know. And then there's AMH. That's more often used nowadays, and that is not cycle day dependent. And in women, usually in the ages of less than 35, ideally, if an AMH level is closer to 2.0, that would be great. If it is less than 1.0, we consider that diminished ovarian reserve. And it also depends on age. If someone's 45 and it's less than 1, then that's not diminished ovarian reserve. That's just the natural ovarian reserve for that age. And then if the AMH is 3.5 or higher, then that we have to think in the back of our minds for possible PCOS. Next slide. There are other fertility tests, and I think Blooming Eve will be hosting another webinar for fertility workup, so I won't go into too much detail, but these are some other fertility tests. These are mostly preconception labs like TSH, vitamin D, blood type. We also make sure that they are immune to rubella and chickenpox, and then communicables. And what are these tests consist of? Like HIV, Hep B, Hep C, those are all required for IVF treatment. And then we offer preconception genetic screening tests just to make sure that the patient and their partners are not carriers for the same genetic disorder. Next slide. What are some other types of evaluation that need to be done? This could also be done in an OBGYN clinic if properly trained, and one of them is called an antral follicle count, and that is a transvaginal ultrasound. And as the ovaries are examined, you're counting the follicles. So those little, with the cursor, those little black circles, obviously those are follicles, but antral follicle counts need to be done in the earlier follicular phase. So typically cycle day 2 to 7 would be ideal. And in that development stage, the follicles measure about 5 millimeters to up to 1 centimeter. If we are measuring anything above 1 centimeter, then we have to think about possible cysts. So anything between 5 millimeter to 1 centimeter, they're counted. And in women who are younger than 35 years of age, if you have between 7 to 10 on each ovary, that's a pretty average number. And then if they have, much fewer number of antral follicles, then we also correlate that with their FSH level and then the AMH level, and they may have a diagnosis of diminished ovarian reserve. If they have more than 12 on each ovary, on one or both ovaries, then we also think about PCOS. So typically 7 to 10, but again, it also depends on age. Other testing that we do, HSG, that could be ordered through an OBGYN clinic as well. And that's mainly to check for tubal patency, as well as tubal anatomy and the uterine anatomy. The saline sonohistogram can also be done in the office, in an OBGYN office as well. And with some training, even saline sonohistograms we can evaluate for tubal patency. And how that works is basically air is injected instead of saline, and those air bubbles are seen traversing through the fallopian tubes and coming out of the tubes. And that's, again, confirming tubal patency. But the best way to look at tubal anatomy would be through an HSG. We also offer office hysteroscopies. I know some OBGYN clinics also do office hysteroscopies. Some are, you can actually do some treatment. Some are purely diagnostic, but we offer office hysteroscopies where we can, if there's a small polyp or small fibroid or adhesions, we are able to correct that for the patient. Next slide. So whenever any patient walks in, or couple, they walk in, we provide individualized care. And this is a team approach. We always say it takes a village to raise a child. It takes a village to create an embryo. It takes a village to have a live birth. And so we are, very conscious of this, and therefore a team approach is taken. and every part of the patient's care and the team is invaluable. Next slide. What are some indications for IVF? Well, for women, it could be purely fertility preservation nowadays. It could be they're not ready to have children, but they're married and they're planning on having kids later on. Then they can consider embryo cryopreservation. They're not sure, they don't have a partner. Egg freezing is also an option. Patients with diminished ovarian reserve, that is a clear indication for IVF where other lesser aggressive treatments are not successful. Tubal issues, again, advanced age leading to decreased ovarian reserve. And in men, it could be sometimes lack of sperm called azoospermia or abnormal parameters in a semen analysis. And in couples who've already failed the lesser aggressive treatments. Next slide. So what is the timeline for IVF? So phase 1, we call it the workup phase. So that's where we can get help from the OBGYN clinics as well, where the required testing or initial evaluation, if already done, could be extremely helpful in expediting treatment. So the workup testing, and then our nurse team also helps with consents, ordering medications, creating a calendar for the patient. And once they're ready to start treatment, the IVF consists of 2 phases. One is called priming and the other stimulation. The priming phase is basically to try to optimize the stimulation phase. So what the purpose of priming is, by giving medications such as birth control pills or estrogen, at times even for very poor responders, testosterone medication is used, and that is trying to have the follicles grow more cohesively, because ultimately we want a recruitment of a higher number of mature eggs. And therefore, priming also can be done or performed at an OBGYN office where we can give all the instructions. And sometimes priming is started after ovulation. So if there's any confusion of when the patient may have ovulated, they can get an ultrasound or a blood test at their OBGYN office. The stimulation phase is where all the monitoring is heavily emphasized. So that's where patients are injecting themselves. These are all subcutaneous injections, and injections consist of the FSH and LH that's needed to recruit follicles. And that is done approximately about 10 to 12 days in duration. And this is to try to, again, grow these follicles to a stage where we can get mature eggs. Next slide. This is just highlighting where OBGYN clinics could help. And again, this is with the monitoring, and monitoring will include ultrasounds and blood tests. Unfortunately, IVF is extremely time sensitive. So these ultrasound reports and blood tests need to be obtained by the fertility center the same day for us to make decisions and then also notify the patient for their same day instructions. Next slide. We talked about. Next slide. The stimulation phase on average is about 10 to 12 days. And the goal is to have a few, at least over 18 millimeter follicles. So it's important that the follicles are measured consistently and accurately, because that's what we are heavily relying on. And these are injections that the patients are instructed to inject themselves, and they're subcutaneous injections. The 3, don't worry about the 3. Those are trigger injections that can that will happen when the follicles are ready. And that is extremely time sensitive. And that is exactly 35 hours prior to the scheduled egg retrieval time. Approximately about 4 to 6 ultrasounds with hormone testing are performed during the stimulation phase. Next slide. This is a sample calendar. Just focus on the first 2 rows. Nowadays, IVF is performed in two parts. There's embryo creation part, and then there's the transfer part. So we're just focusing on the embryo creation part, or the egg freezing part, which is exactly the same. There is an initial ultrasound called baseline or suppression check, where the ultrasound and blood test will just confirm that there are no cysts on the ovaries, all the hormone levels look the way they should look at the beginning of the follicular phase. Then they are approved to proceed. And once the stimulation injections have been started, then the patient will come back, typically on stimulation day 4 or 5, depending on the clinic. And again, we are assessing the progress. And so again, we can't emphasize enough the consistency of the ultrasound, the follicle measurements, and also it would be great to have a dedicated lab that could give us consistent results and same-day results. So then initially the monitoring is done every 2 to 3 days, but near the end, then it's almost daily. Again, the process can differ from center to center, but this is just a basic overview. Next. Anastasia, could you talk a little bit more about this app?
Yeah, this is more about communication. So different centers have different approach as well. So this is, I guess, CCRM and some other centers have the patient app where the patient gets notified with their appointments and their medication and things like that. But that is pretty much it.
I thought it was a special picture, so I wanted you to answer that. Okay, so this is the ultrasound of a developing follicles, and I was hoping to have a cursor to kind of show you how to measure those follicles. So as you can see, the outlined follicles down in the right lower corner, they have all different shapes. So this is where it can get a little tricky in terms of consistency and how you should measure these follicles. So those oval shapes, so we never try to measure kind of diagonally crisscross. We go from like longitudinal and then horizontal. So and then some oblong shaped follicles, we go with the longest distance and then kind of not the widest, but kind of average it kind of right in the middle. So, but overall, you'll get the hang of it. We have communication with other, physicians who may have questions on how to measure, and then basically after a few ultrasounds, everyone can get the hang of measuring follicles. Next. For lining, as you can see, there's the outline there, and this is an image of a follicular phase lining, and you can see that triple line pattern. So not only is the thickness important in measuring, but also writing in the report the quality. So is it triple line? If it's in the luteal phase, then the lining looks very hazy and white, and that's called isoechoic. So that's important for us to know. And then if you note any hyperechoic lesions, that can indicate polyps or fibroids. Those things all need to be in the report. Images, if we can get, that will be great as well. But the report, if detailed enough, would be sufficient. In terms of measuring the thickness, the embryo is typically transferred in the kind of the upper third from the fundus of the cavity, and therefore measuring kind of that thickness in that area would be ideal. Next. So on the day of the retrieval, so after the trigger injection is given, 35 hours later, the patient comes in for the retrieval. They are given, they are undergoing the retrieval under general anesthesia. They are not intubated. This is all done through the IV. They're given propofol and fentanyl for pain. So they are out. They are taking a nice little nap for 20 to 25 minutes. And the procedure is done vaginally and under ultrasound guidance. And afterwards, they stay in the recovery room for about 30 minutes to an hour, and then they go home. All the mature eggs are then inseminated a few hours afterwards, and the embryologist will let the patient know the following day with fertilization results. In terms of recovery, it all depends on the number of eggs retrieved. For patients, I always say life is fair, because if patients get lots of eggs, they have a more challenging recovery. If they have fewer eggs, then their recovery is actually very easy. But most people are up and walking that same day. But if they have a lot of eggs, then that bloating and discomfort can last up to a week to 2 weeks. So we do give precautions based on the number of eggs, or how many. We even start all the precautionary measures, even during the stimulation, based on the number of follicles. Next. So on the far left, this is what a mature egg should look like. It's all clean. So egg initially, as soon as they're retrieved, they don't look this clean. They have layers of cumulus cells, and those are all stripped off, and that's how the lab will identify which eggs are mature and immature. So these are mature eggs, and you can see those little polar bodies. And in terms of fertilization, there's two types of fertilization. One is called standard insemination, where droplets of concentrated sperm are placed into the petri dish, and the sperm are then left alone to fertilize the eggs. Then there's the other procedure called ICSI, or intracytoplasmic sperm injection, where the embryologist will then choose one normal morphology, active sperm, and then inject one directly into the egg. At CCRM, we only do ICSI, and for two reasons. One, if you leave the sperm, droplets of sperm, and allow them to fertilize the eggs, there's a possibility that maybe 2 or 3 sperm can enter the egg. So CCRM we want to eliminate the possibility of abnormal fertilization as much as possible. It still can occur even with ICSI, but in terms of if the egg has an extrapronuclear, abnormal fertilization still can occur, but we're trying to minimize that as much as possible. And therefore, that's one main reason. The second reason is when in standard insemination, the eggs are usually not as cleanly stripped. There's layers of cells still. And with the sperm binding, by the time the embryo develops, if the embryologist cannot, with their naked eye, see a sperm head that could be attached, and then they undergo a biopsy, then could that biopsy result not be accurate? Because now it's looking at 2 sperm heads, 2 sperm and 1 egg. And so again, CCRM wants to eliminate that possibility and know that the result for the genetic screening, which I'll go over in a little bit, the genetic screening test results are from 1 egg and 1 sperm. Fertilization rate is about 70 to 75%. And the picture of this fertilized egg, you can tell because it has 2 pronuclei, one from the sperm and one from the egg. Next slide. And day 1 is considered the fertilized egg, and we let the embryos grow to day 5, but even up to now day 6 and day 7. So day 5, day 6, day 7 are called blastocysts. Day 3 is considered a cleavage stage embryo. Okay, and therefore we at the stage of the blastocyst, then we're able to grade these embryos. Next slide. And also assess the maturity of these embryos. So the top part was the drawing. That's it's labeled as 1, 2, 3, 4, 5, 6. That's showing the maturity of the blastocyst, dependent on the expansion of the blastocyst. So 6 is almost now like it's hatching. We would consider a transferable embryo and a biopsyable embryo starting from the maturity of level 3. Okay. The bottom picture images, it says A, B, and C. So the black arrow is in the A box. The black arrow is pointing to a tight group of cells that is called the inner cell mass. And that's what is responsible for developing the baby, the fetus. And then the white arrow in that same box, you can see lots of cells. And those are cells that will become the placenta. And it's also called the trophectoderm. And that's an A grade for both the inner cell mass and the trophectoderm. The B box, or B grade, you could tell that the cells are not as tightly bound, and they're a little bit looser and also fewer in quantity for both the trophectoderm and the inner cell mass. And then C, we don't even biopsy Cs because the likelihood of a live birth is extremely low, and it's impossible to remove a few cells from an embryo that doesn't have many cells to begin with, and therefore C grades are typically not biopsied. There may be fertility centers that still biopsy C grade blastocysts, but at CCRM we only do A's and B's. So when you get the embryo report or from a patient and you see those two letters like ABs or BBs or AAs, that's what it's representing. And then the first number, you might see a 4AA or a 3AA. Again, that's the maturity of the blastocyst. And then most importantly, it will say day 5, day 6, or day 7. Next slide. So after now the embryos are created, what happens? Well, in the olden days, we did a lot of fresh transfer, but we don't do that as much anymore because screening these tests through what's called PGTA, or pre-implantation genetic testing, and A stands for aneuploidy, can filter out the abnormal embryos. And by transferring only normal embryos, it can significantly increase the live birth. So fresh transfers are not done as often, although we still do some. But when we do the fresh, and that's usually per patient request, but we do some fresh transfers, and typically those are done on day 3s. And the theory behind doing a day 3 transfer is just in case in those patients where maybe those embryos might do better in the uterus than in the laboratory. And those are more for patients who have very low blastocyst conversion rates, or who just don't produce too many, and we want to transfer all. And very select case of select patients are given the option of a fresh transfer. Freeze-all, those are for patients who are not interested in transferring, and they are just wanting to do embryo banking. But we would freeze anyway for patients who undergo the genetic screening test, and immediately after the biopsy, they're frozen. Next. This is just an image of how a biopsy is performed. To the right, it's a very, very small, thin pipelle that is removing about 3 to 5 cells of the trophectoderm. Notice that on the left, which is the inner cell mass, it's not being touched. We don't touch the inner cell mass, only the trophectoderm. And 3 to 5 cells are removed, and those cells are then sent to a genetics lab for analysis. After those 3 to 5 cells are removed, the lab will immediately freeze the embryos. Next. Next. Oh, that's the inner cell mass.
Yeah. I got stuck. Yeah. Sorry. Here.
Yeah. Great. So what happens with these abnormal embryos? Well, typically, severely abnormal embryos will arrest in culture. They won't even develop further. But if they get to a stage where they're not tested, screened, and they're transferred, a lot of times they fail. They don't implant properly, or they don't implant at all. And if they do implant, there's a very high rate of miscarriages, even very early miscarriages, such as biochemicals. And then there are some abnormal embryos, such as Down syndrome or trisomy 21, that can result in a live birth. Next slide. So maternal age is the highest risk factor for aneuploidy, or chromosomal abnormality. I know this is a kind of a complicated slide graph, but I'll explain it in a nutshell. Basically, in women who are younger than 35 years of age, so the blue stands for euploid or chromosomally normal embryos. The red, green, and purple are all chromosomally abnormal. So typically in women who are younger than 35 years of age, the chromosomal abnormality rate anywhere from 30 to 40%, we say approximately about 30%. Then from 35 to 37, more like 40%. And then from 38 to 40, more like 55 to 60%. And then from 43 and over, about 85% and higher. The 46, please ignore that. That's an outlier. We don't know why that 46 has a higher rate of euploid than a 42-year-old. But yeah, so typically by the age of 46, it's well over 90% the embryos are chromosomally abnormal. Next slide. So then now we have these embryos. We talk about fresh versus frozen embryo transfer. Well, fresh cannot happen if we're a biopsy. Yes, in some places, sometimes the turnaround from the biopsy to the results could be very quick, but ideally the embryos at the blastocyst stage, once they're biopsied, they are frozen, and only frozen embryo transfers can be done. The fresh embryo transfers I had discussed, that's purely based on the overall appearance of the embryo, which embryos to choose. Day 3s are graded a little differently than day 5s. And then what can happen is you're not transferring these embryos in an optimal state because these are hyperstimulated ovaries. The uterus has been exposed to high levels of hormones. It's not physiologic. So frozen embryos we consider more physiological, and hopefully the uterus is more in an optimal state. And again, most importantly, you can chromosomally screen them. Next slide. We say the frozen advantage has higher, frozen embryo transfers has higher implantation rates, ongoing pregnancy and live birth rates. And again, decreased risk of severe ovarian hyperstimulation, because as you know, ovaries are hyperstimulated, but once that embryo implants and starts secreting the HCG, ovarian hyperstimulation can be much more prolonged and very, very uncomfortable and even occasionally dangerous for the patients. Next slide. So this is another process where outside monitoring could be extremely helpful for patients who do not live close to their fertility centers. Embryo transfer cycles or protocols can vary from a natural cycle where you're just monitoring the own menstrual cycle and trying to time it appropriately by monitoring with ultrasounds and blood tests. The medicated cycle, patients are not ovulating and they are controlled solely with medications and given high doses of estrogen to thicken up the lining, then adding progesterone, and then 6 days later doing the transfer. Usually with the medicated protocols requires maybe 2 to 3 visits to the outside monitoring centers, and that will consist of ultrasounds and blood tests, exactly like a IVF stimulation monitoring, the IVF monitoring. But in the natural cycle, there can be more frequent because we have to be very, very, we have to closely monitor, because if the follicle ovulates or we lose that window, then we have to cancel the entire transfer cycle. And therefore, with outside monitoring, most likely medicated protocols would be much more manageable. But then again, we have to see what the patient will benefit from. And it all depends on their clinical history as well. So the embryo, so after the decision is made and they start the progesterone or they're triggered, then they're scheduled to come in and will come to the fertility center for the embryo transfer. Next. The comprehensive chromosomal screening, CCS, also called PGTA, we talked about this, but will allow us to perform single embryo transfers and while maintaining pregnancy rates, high pregnancy rates. Next. By performing single embryo transfers, it does reduce multiple births. That's not what we want. It reduces preterm delivery, complications during pregnancy, such as miscarriages, preeclampsia, and gestational diabetes, and then due to sometimes preterm delivery and multiple births, neonatal morbidity. Cycle. Next. So Dr. Schoolcraft looked at this, and this was back in 2013 when he published this data, looking at Group A, which would be the fresh transfer, and these are in women who are similar in age, but Group C tend to be a little bit older. Group B are frozen embryo transfers that have not been tested, and then Group C are frozen embryo transfers with embryos that have been screened. So you can see that the ongoing pregnancy rates are significantly higher in the Group C patients than Group A. And again, we see that very commonly in our patient population to this day. Next slide. Okay, this is just CCRM overall data. What we want to show is that the navy blue is kind of the national average. The red is which is overall embryo transfers with non-tested embryos, and then the light blue is the live birth rates with tested or screened embryos. So as you can see, almost the age factor is eliminated. You have such a high success rate also in patients who are in the age of 41 to 42 category. The challenge is, though, getting that normal embryo in this age group, because as I've mentioned earlier, the quality and quantity of eggs significantly decrease with age. And therefore, in this category, the likelihood of the patient undergoing multiple cycles to get that normal embryo is very high, compared to someone who's younger than 35, maybe only one cycle is needed, and they still have enough to freeze for future babies. Next cycle. Next slide. So the current fertility care model is inefficient. Patients schedule their first appointment with the fertility clinic. Some clinics are booked out already a few months. And then once they see their physician, then they start the workup process. Again, that workup phase lasts about a month. Then they meet with their physician again and to go over all the labs, and then they will start the treatment cycle with their following menstrual period. So that process can be significantly shortened if OBGYN clinics or physicians are educated about the workup that's needed to start fertility treatment. And the workup is typically the same, whether it's IVF or IUI or with the lesser aggressive treatments. So this same workup can be done. And then they would be referred to a fertility specialist. And at that appointment, because the testing has already been performed and we have the results, the physician is then able to create or at least discuss the best fertility treatment option for the patient, and then also then determine a protocol for them to start sooner. Then the patient doesn't have, if they live far away from a fertility center, they can undergo the monitoring with their local OBGYN, and then come here for the retrieval or the embryo transfer. So fertility clinic gets results and finishes the cycle, and that will significantly shorten the overall process.
And that is exactly what Bluminiv is helping OBGYN practices with. So yeah, would be happy to tell you a little bit more about that at the end of the presentation. And so in here, it's basically what it is, what the outside monitoring allow the OBGYNs and the patient to get. So the patients who are living hours away from fertility center or don't have affordable fertility clinics around them, it's in your hands to help these patients to get their treatment earlier and to save time and money in commute and also transferring all these documents. And in addition to that, when you start the outside monitoring at your practice, you can earn extra money from this ultrasounds and blood work visits, as Dr. June show in the timeline. So they are around 4 or 6 for on average, but it can differ from patient to patient. You also can keep your patients in the practice because they do the monitoring. They basically come back to you when they are pregnant. And that is basically it. Thank you so much, Dr. June. It was so informative. I feel like I learned so much from you. And I'm sure that everyone who attended the webinar learned as well. So we would be sharing the recording for this webinar after we finish in a few days. So maybe right now we have time for a few questions from the audience. If we have any questions, let us see.
Feel free to raise your hand. I know that Q&A might be hard to find here, so you can raise your hand and I will enable you talking. I did have a question actually about you mentioned that it's extremely important to monitor closely the patient. Are there any edge cases you've seen? What can happen if the patient is not monitored closely, and how often do they happen?
Right. Usually, currently, a lot of the outside monitoring is done at other fertility centers, right? So they understand what's how the follicle should be measured, what the importance is. It's very time sensitive for certain protocols where if the follicles are not measured appropriately, we can miss that window where we can add a medication to prevent ovulation. So if that medication is not started at the appropriate time, then the entire cycle can be a failure because the patient prematurely ovulates. So it's really important that we get the results in a timely fashion. Again, another important factor is triggering on that trigger time. The earlier, like stim day, we call 1 through 4, not as critical, but when it gets closer to the triggering time, it is extremely important because timing of the trigger can also affect the quantity and quality of the eggs that we may get.
Yeah, thank you so much. So it seems like no one wants to ask any questions. Yeah, that's why I said it was informative, so that there are no. Oh no, we have. Okay, we have someone who wants to ask. Okay, so now you, Andy. Now you can ask the question that you have. Please unmute yourself. I think you would be able to. Okay.
Can you hear me now?
Yes.
Yep.
Do you recommend the same ultrasonographer perform all of the ultrasounds for one particular patient just for continuity and consistency, as well as the same lab?
I mean, currently in our practice, we have 3 ultrasonographers who have been trained to know how to measure the follicles. So no, we don't necessarily need a single ultrasonographer to measure the patient throughout the entire cycle. However, they do need to, if they're covering for each other, they need to also get the proper training so that there's not too many inconsistencies. The lab, I do think, can vary. And so the lab, I do emphasize it is important to be consistent with one lab because estradiol levels HCGs, as you know, too, can vary, right? So it is that would stress, if at all possible, to get it, to have most of the labs drawn in one lab. But ultrasonographers doesn't have to be the same person. Ideally, yes, if possible, but it doesn't have to.
Thank you.
Any more questions? Anyone? We have a few more minutes left. Okay, so while we are waiting, I will share about BlueMeNIF pilot. So if you want to start introducing IVF monitoring at your practice, you can contact us. Here is my email, and we will set you up. As Dr. June mentioned, we provide the training. We also help you to provide the results for monitoring, like blood work and ultrasound at the same day, so that the patient cycle is correct, and the physician in area can do any modifications if needed, even though the patient is not where the fertility center is. We also have a special offer. If you sign up for our pilot by the end of the month, we have the implementation cost off, so you would save more than $2,500 on that. So if you are interested in that, please reach out and be on the lookout for our upcoming webinar about fertility workup, both for females and males. So please be on the lookout for our next email with the invite. Any other questions? Well, if we have no questions, Dr. June, it was such a pleasure. Thank you so much for sharing your wisdom and sharing all this information. We learned a ton, and thank you so much. It was so great to have you.
It was a pleasure. Good night, everyone.
Good night. Good night, everyone. Thank you for joining.